Greetings, everyone, and welcome to the ECG Case of the Week for July 3rd, 2017. This is Amol Mattu at the University of Maryland School of Medicine. This week we're going to talk about a bread and butter topic in emergency medicine. We're going to kick things off with this case. We've actually got 4 cases to discuss. And this first one is coming to us from the United Arab Emirates by Dr. Hirwa Kagabo Dudene. I hope I'm getting that name right, but he recommended that I just refer to him as Dr. Kagabo. So that sounds a little bit easier. Dr. Kagabo has actually sent a couple of cases that we've discussed in recent years, and this is another really nice case. This is a 55-year-old man that he was taking care of who presented with some intermittent chest pain over the past 4 days. This patient's only cardiac risk factor is smoking about a pack per day of cigarettes for many years, and at the time of arrival, the patient actually has no symptoms at all. But of course, we're going to get a 12-lead ECG, and this is what he was looking at, and he had some obvious concerns. Take a look at this ECG, and what is it that you are concerned about? And I'll also ask you, what do you think is going on based on the ECG findings here? Well, Dr. Kagabo was really worried and actually sent the patient for an urgent cath, and I underline urgent. It wasn't an emergent cath. He didn't necessarily activate the cath lab and say you need to go immediately, but it was pretty quick that this patient ended up going for a cath, and some of you may know what this cath revealed: a 95% left anterior descending artery stenosis. The patient ended up getting a stent and ended up doing well. And so what we're going to talk about this week is something that he noticed on that 12-lead ECG. It's something that we refer to as Wellens waves. Now, many of you probably know about this already, but we're going to review it again because there's a lot of new listeners, and I think there's still a lot of confusion about this. Wellens waves refers to this T-wave pattern in the mid-precordial leads. When I say mid-precordial, what we're really talking about is leads V2, V3, and sometimes V4, this biphasic T-wave pattern in the mid-precordial leads. Now, some of you may recall that in previous weeks we've talked about this biphasic pattern that goes down and then up, and that is a sign of hypokalemia, and I refer to that sometimes also as a reverse Wellens wave. But this is what Wellens wave actually is. It's this biphasic T-wave pattern in the mid-precordial leads, or sometimes it can be a deeply inverted T-wave pattern, which we'll talk about. And when you see this biphasic T-wave pattern, it tends to be relatively predictive that the patient has a proximal left anterior descending artery stenosis. So let's talk a little bit about this Wellens waves or Wellens syndrome, and I'm going to distinguish those two terms just a little bit. First, let's talk about what the formal definition of Wellens syndrome is. This is something that was first described in the early 1980s by a few cardiologists, and it was named after the senior author, Heinz Wellens, who's still out there doing some really great publishing and research on electrocardiography. And what they found was that there is a specific T-wave abnormality present in the mid-precordial leads, which would predict a proximal LAD critical obstruction. 80, 85, 90, 95% or 100% proximal LAD occlusion. Now, there's a couple of things that they use to define the formal syndrome, or rather the formal definition of this syndrome. Number one, there really should not be loss of precordial T waves. In other words, if you've got Q waves in those precordial T waves, then a lot of times this is just a reperfusion abnormality. In other words, it means a person's already infarcted, and it may just be a sign that they have hopefully successfully reperfused. Sometimes, in fact, you see this in patients that have an anterior wall MI after they get the cardiac catheterization and the arteries opened up. So it can be a sign of reperfusion. So what they said was that this is not something to think about when you see Q waves. There should still be some R waves present. In other words, the patient has not completely infarcted already. There is 2 patterns that they talked about, type 1 and type 2. Sometimes people use the terms type A and type B, and I've seen in some literature these two are interchanged, and this is referred to as type 2 and this is referred to as type 1. You know what? It really doesn't matter. The key thing is to be aware that there's 2 types of patterns that you can see. Type 1 pattern is deeply inverted T waves in those mid-precordial leads. I don't even usually like talking about that because nobody is going to miss that. The reason I like talking about type 2, this biphasic pattern, is because this oftentimes is missed. Your computers oftentimes refer to these biphasic T-wave pattern as just non-specific T-wave abnormality. Sometimes the people interpreting the ECG will refer to this as a non-specific T-wave abnormality, and what I hope to convey to you is that this is not non-specific, but in the right patient, when you see this biphasic T-wave pattern, it is actually fairly specific for a proximal LAD occlusion. Sometimes people say, how specific is it? In the literature that I've seen, which has looked at this, not great, perfect, randomized, double-blind, placebo-controlled study type of literature, but decent literature has suggested that this is more than 80 or more than 90% specific. So it's something that you've really got to worry about in the right patient. So who is the right patient? These generally are patients that are coming in who have been complaining of some type of cardiopulmonary complaint, and that's the reason that you got the 12-lead ECG. Now, a few other things that are part of the formal definition of the syndrome. We already mentioned that you shouldn't see Q waves. For the most part, you still should see R waves in those mid-precordial leads. In the original description, ST changes were often absent. In other words, you don't need to see ST segment elevation. We'll get rid of all this, but notice that in these examples, there really is no significant ST segment elevation. It's purely a T-wave abnormality. So ST changes are not reliable. Also, one of the key features that they described is that this ECG abnormality is present in the pain-free state. So this is not just a T-wave abnormality you'll see in people that are having symptoms. They may have persistence of this T-wave abnormality even after the pain and all other symptoms have resolved. They're totally asymptomatic. That's part of the definition of this syndrome. And finally, cardiac biomarkers typically are normal. The CBK, MB, the troponin, you can't rely on those. Oftentimes the biomarkers are normal. In other words, the patient has not necessarily yet infarcted. Now, some people say, well, what about those new highly sensitive troponins? Maybe those will be elevated. Maybe. I haven't seen literature on that topic yet. You know, those highly sensitive troponins are positive in so many patients. In fact, patients that have nothing going on. It wouldn't be surprising to me if a lot of these patients do have bumps in their newest generation highly sensitive troponins. But again, for the most part, I'm going to tell you, you cannot rely on biomarkers to be positive. You've got to read the 12-lead ECG. Now, a couple other key things about this syndrome as it was originally described in the early 80s. These patients, because they have a proximal LAD occlusion, as you'd expect, are best evaluated invasively with cardiac cath. Stress testing is not a good idea. In fact, some case reports out there, and I'll show you a case today. We've talked about a couple cases before, where stress testing can actually precipitate an MI and cause decompensation, which makes sense. If you knew that somebody has a big, 90-95% proximal LAD occlusion, the last thing you want to do is to put them on a treadmill. That doesn't make sense. And so if this EKG is telling you that somebody has a proximal LAD occlusion, stress testing is not a good idea. So don't put them on a treadmill and stress test them. What about chemical stress testing? Well, maybe that's probably, I'm guessing it's probably safe, but putting them on a treadmill is not a good idea. In general, these patients are best evaluated with cath or PCI, or coronary CTA would be a reasonable thing to do as well. The other important thing to know, medical management does not tend to work. Again, no big surprise for a symptomatic proximal LAD occlusion. Your aspirin and your heparin and your clopidogrel and discharge them on a statin. No, that's not going to work. Patients with big proximal LAD occlusions that are becoming symptomatic, those patients need invasive therapy. Medical management doesn't tend to work for those patients. And when medical management alone is attempted, in their original description, about 75% of these patients went on to develop a big MI or die within 2 to 3 weeks. No big surprise. Again, a proximal LAD symptomatic occlusion, those patients need invasive management, not medical management. Those patients are going to have a bad outcome if you just sit on them with medications. There's a few miscellaneous points that are not well published, but based on a lot of observational data that I and other people have found, there's a few things that I would like to add to your knowledge about Wellens syndrome. First of all, it's best to make this diagnosis in the absence of high voltage or LVH. what we find is that when patients have gigantic QRS complexes, the T waves can oftentimes be screwed up. You can often get some biphasic T wave patterns, or you've seen LVH with repolarization abnormality where the T wave is sagging. Bottom line is, when you've got giant QRS complexes, the T waves that follow are going to be screwed up. Yes, that is the technical term. They get screwed up. They can be biphasic, they can be sagging, they can be depressed, they can be inverted. So it's best to make this diagnosis in the absence of LVH or high voltage. In other words, in the absence of large QRS complexes. It's most reliable when the QRS complexes are kind of moderate normal size. Second point, as more and more literature has come out, we have found that a lot of these cases are not proximal LAD occlusions, but oftentimes mid or even distal LAD occlusions. So, the way I think of Wellens is that it's a predictor of LAD, not always proximal, probably most commonly proximal, but not always. But either way, it doesn't matter. Just worry about the LAD. Another key point here is that it does not always just appear in the pain-free state. Sometimes you're going to see those Wellens waves even in patients that are actively having symptoms. So again, the formal definition of Wellens syndrome is, as it originally described, it occurs in the pain-free state, but sometimes you're going to see these Wellens abnormalities, the T-wave abnormality, which Marriott used to refer to as Wellens waves. Sometimes you're going to see those Wellens waves even when the patient is having pain, and it may come and go based on their pain. So I don't really focus too much on whether they're having pain or not. Some of the purists out there will say, well, you can't call it Wellens syndrome if they're having pain, to which I respond, get a life. I'm more concerned about the T-wave abnormality, and I'm going to be worried about those patients whether they're having pain or not. So key point, they can have the symptoms or they cannot be having symptoms. Either way, if they have those Wellens waves, I'm going to worry about the LAD. And then finally, another key point that I want to make, which is also sometimes a point of confusion. This is not currently listed as an indication for emergent cath or lytics. Remember, the indications for emergent cath or lytics are based on ST elevation, not T-wave abnormalities. So if the patient doesn't have ST elevation, technically you're not activating the cath lab emergently for these patients. Now, is it wrong to do that? No, it's not. But most of the cardiologists out there are not going to take somebody to the cath lab who doesn't have ST segment elevation just purely based on the T-wave abnormality. So I can't argue with them for not wanting to take them. What I would recommend, though, is that if you're calling up your cardiologist and say, hey, I've got a patient here with Wellens waves, I'm really worried, and they say, no, there's no ST elevation, so I'm not going to take them, fine. Stay on top of that patient, get serial ECGs, and bring him into the hospital, and they'll probably end up needing to go for cath in the next couple of days. So Wellens syndrome or Wellens waves oftentimes is an indication for urgent cath, meaning in the next couple of days, not necessarily emergent cath, which means in the next hour or so, right? So they're probably going to need a cath, but does it need to be done at this moment? Well, if there's no ST segment changes, they probably don't have formal criteria to go for cath. If your cardiologists want to take them, that's great, but a lot of them will not. And one other key point, if the symptoms are changing, get serial ECGs. How often have we had to say that before? If the pain comes, get an ECG. If the pain goes away, get a new ECG. Take a look at evolving changes on that 12-lead ECG. Some of them will evolve into a STEMI during the course of the ED. We've covered some cases like that in past podcasts where the patient starts out with the Wellens and over the course of the next couple of hours, they turn into a STEMI. So I'm a big believer with these patients in getting serial ECGs, especially if any of the symptoms are changing. And then the last miscellaneous point I want to make here is that many of your consultants don't know about this. And that's, again, it's not meant to be a slam against the cardiologists or internists or hospitalists or the folks upstairs. It's just not necessarily something that they're reading about. But if you know about it, you need to share the literature with them, explain to them what you're concerned about. But again, don't be surprised if a lot of the folks upstairs don't know about Wellens. That's fine. They're reading other stuff. You're the one that has to know everything there is to know about Wellens syndrome. All right? Okay, let's do a couple more cases just to really hammer home this pattern. Case number 2 was sent by Dr. Kim Baldino, who works in North Carolina. She was taking care of a 61-year-old man who presented with atypical chest pain. He had some sharp pain that was located near his shoulder. There was no radiation. It was not associated with exertion, so it's a bit atypical. It was intermittent, lasting only for a few minutes at a time. So again, this isn't really knocking my socks off, and it probably wasn't knocking her socks off either, but she got a 12-lead ECG, and here it is. Well, there's a lot of ectopy here, and it looks like there's sinus rhythm with some ectopic beats in there. But again, we're talking about Wellens, so everyone's hopefully going to be focusing on the mid-precordial leads, V2, V3, V4, and there's not a lot there either. This is not knocking my socks off either. I'm looking down, and my socks are still on, so it's not knocking my socks off. She got initial troponin, and it was within normal limits at their lab. So she did a heart score on the patient. The heart score came out to 3. Now, a lot of people would probably say that with the heart score of 3, you can probably justifiably discharge this patient home. But what she wanted to do, instead of using the pure heart score, use the heart pathway, which maybe we'll talk about some other time. Essentially, the heart pathway just incorporates using one additional troponin about 3 hours after the first one, and also an additional ECG. The repeat troponin turned positive. It was greater than the upper level of normal, and so she got another ECG. Here's the repeat ECG, and, well, I'm looking down and my socks are still on. This is not knocking my socks off either. Let's take a comparison of the two ECGs. On the left, you've got the triage ECG. On the right is the new one, and maybe there's a subtle change in a couple of the leads, but I don't want you to have to imagine stuff. I would overall say that this is not a huge concerning change here. Still no formal Wellens waves or Wellens syndrome up here. But despite that, because the troponin had turned positive, she tried to activate the cath lab, to which cardiology said, no, there's no ST segment elevation, so we're not going to take the patient to the cath lab, which is reasonable, but you need to really stay on top of this patient. And so what they did, they admitted the patient, and they got another relatively quick ECG, and the repeat ECG later in the day, well, now it's very obvious this is a classic Wellens biphasic T-wave pattern, and in V3 it's frankly inverted T-wave pattern. In V4 and V5 there's T-wave inversions as well. So now it becomes very easy, and the serial ECGs made all the difference in the world. So at this point, the patient now gets to go to the cath lab, and no surprise, 95% proximal LAD occlusion. How about another case? This is sent from Iceland. I think this is the first case that's ever been sent to me from Iceland, so I had to include this. This is sent by Dr. Jan Hansel, who is a first-year resident, and she was taking care of a 55-year-old man in a rural general practice clinic. Patient presented with abdominal pain, which was radiating to the chest, the neck, and both arms, so that's very concerning. It's abdominal pain, so I'm not really sure what to do with that. But there is some radiation to the chest, and now I'm concerned, and it's radiating to both arms. That's sounding very concerning. The patient says that it only occurs with biking, and it's been going on for 3 months. And this guy bikes 5 miles per day, so it seems like he's pretty healthy. And Janet said his cholesterol is normal, and he gave up smoking 30 years ago. It never occurs at rest. His vital signs are completely normal. He's not obese, and so really not major risk in terms of his initial demographic profile. But he's got some concerns up there, and Jan was concerned enough that she decided that she was going to get an outpatient stress test in the next few days, and let's check a quick 12-lead ECG. So the ECG was done. The nurse stuck it in her mailbox, and Jan saw the ECG later that evening after the patient had already left for home. And here's the ECG, and you can see Jan circled lead V4. The T-wave inversions up there, V3. V2's got your classic Wellens waves, which she recognized. She knew all about this. And so she called a patient at home in the evening and said, you need to take a couple of aspirin. True story. She told this patient, take 5 Bayberry aspirin, and go immediately to the closest cardiac cath hospital. And that's what he did. So she found out which hospital he was going to. She called up the cardiologist over there and talked to him about it. And this cardiologist agreed with her concerns for critical LAD. He understood and knew about Wellens. So they took this patient for immediate cath lab activation. And there's your cath. 95% LAD stenosis, which was predicted based on that EKG. The patient ended up getting a stent and did well. And by the way, when the patient went to this other hospital, they checked the troponin before he went up to the cath lab, and it was 150. So this patient's troponin was positive, highly sensitive troponin was positive. So this technically wouldn't meet the formal definition of Wellens syndrome because the biomarker is positive, but who cares? Get a life. You've got those Wellens waves, so you're going to be concerned about it. And it's a darn good thing that he didn't get a stress test, right? An exercise stress test could have potentially been deadly in a person with a 95% proximal LAD occlusion. Speaking of stress tests, let's do this case. I've done this case a couple of times before. It is a classic case that I think we can never do too often. People need to understand the concerns with stress testing. This was sent to me by Dr. Tony Arguilla from Long Beach, California, several years ago, and I keep talking about this case. This is a 58-year-old man who came in with some concerning chest pain. It got better with nitrates. Tony got a 12-lead ECG, and there you see the Wellens waves, biphasic, a bit in V2, definitely V3, definitely V4, and some T-wave inversions out laterally as well. So Tony's really worried about Wellens. By the way, take a look at the ECG interpretation. ECG machines don't know about Wellens. They just call them non-specific. Don't rely on your ECG machine. Well, Tony was all over this. He knew about Wellens. He admitted the patient, and he specifically told the inpatient team about Wellens and about the dangers of stress testing. And what do you think they did? They said, well, we need to get a stress test anyway. So they sent the patient for a stress echo, and now what do you think happens? The patient develops ST elevation, then has a cardiac arrest. During the stress test, they had to run a quick code on the patient. Fortunately, they got the patient back, full neurologic recovery, thankfully, and the patient went for an immediate cath and had, no surprise, proximal LAD stenosis. So I would imagine that pretty much anything Tony says in that hospital, people believe him now. Unfortunately, it took a cardiac arrest to get that. Okay, so let's do some quick take-home points about Wellens syndrome or Wellens waves. Remember, the deeply inverted T-wave inversions, no one's going to miss that. But the biphasic pattern, you've got to worry about. That's oftentimes called nonspecific on the ECG machine. Don't believe your machine. It predicts a critical occlusion or stenosis in the proximal, usually proximal LAD. You cannot rely on the machine, and be aware that many of your consultants won't know about this. Have a low threshold for getting serial ECGs, especially when the symptoms change. It may turn into a STEMI during your shift. And be very careful about stress testing. Don't do exercise stress testing. If you really have to do a stress test, I'm guessing at this now, I suppose nuclear medicine stress testing might be safe. My preference, though, is either send them a cath, or if you can't do that, at least get a coronary CTA, because that should pick up big LAD occlusions. All right, folks. Well, I hope this case was helpful. We'll do more Wellens in the future because I've got so many great cases of Wellens, but we've only got limited time with each week, so I don't want to do all of them this week. We'll save some for next time. I hope this case was helpful, and I look forward to talking to all of you next week. Bye for now.